Thanks so much, Ruth. Good evening, everybody. You are very welcome to this webinar, the collaboration between the Royal College of Podiatry and Orthopaedic Research UK. This is a new project for us. We're all very excited about it, and it's great to have so many of you joining us tonight. So my name's Gavin Spence. I'm a children's orthopaedic surgeon, and I have three co-conspirators on the panel with me. My friend and colleague, Michalis Kokonakis, who is a fellow surgeon. He works at the Evelina Children's Hospital. And we have Nina Davis and also James Welch, podiatrists, both specialists in children's practice. So they're both on the Children's Podiatry Special Advisory Group. So we have four of us here, two different professions, but what we share is an interest in pediatric practice, an interest in teaching, and an interest in learning from each other. And the title of the webinar, as you see, is Growing Pains. So it's a bit of a play on words, really. We are going to talk about growing pains. That is an important condition to discuss. But we're also kind of referring to those sort of baby steps as we sort of learn how to collaborate with each other, because that's really what this project is all about. There is enthusiasm on both sides to learn each other's trade and learn how we can work together. So we're kind of using growing pains as an example, but we're interested in learning how podiatry and the world of orthopedics can work together in pediatric practice, because at the moment that's not a very developed thing. So a couple of things to tell you. The collaboration has already started, as you may or may not be aware. So there is a podcast which the four of us have already recorded. It's called Serial Casting. See what we did there. You can access that for free on any of your favorite podcasting platforms. That's the first one. Hopefully there will be more, so have a listen to that. There is also, and you've hopefully been notified about this, there is a website called podinote.com. This is a discussion forum. It's free to join. You just have to click on the sign up button, and then you can post cases for your peers to look at. You can ask questions, you can ask for advice, and so on and so forth. Also, the cases that we're going to discuss tonight are on that platform, so strongly encourage you guys to sign up to that. Now, this podcast is going to be done on Zoom. I'm sure, post-pandemic, everybody knows how to use Zoom. But what we have learned over the years, it's really important to try and be interactive. And there's loads of you out there. We're really keen to get you guys involved. So how do we do that? There's a few ways. First of all, with polls. So there are going to be some polls popping up through our presentations. Please just click on your answers on the polls. It's just for fun. Nobody's recording it. It's not an exam. Just give us your thoughts. It really helps to sort of see how everyone's thinking. So those polls you'll see, they'll appear through the presentations. The second thing is there's a thing at the bottom of your screen, the chat box. So this is where you can interact with us. You can ask questions, you can make points that you want to bring up. But one important thing, when you click on the chat, you can then send it to somebody or everyone, and it will default to everyone. So please write your question, but don't send it to everyone. Instead, send it to me personally, and I'll either reply to you or I'll pass it on to one of my co-panelists who's better placed to answer it, or I'll store it up and we'll break from time to time between the presentations and answer your question. But it's important that you send it to me, not to everyone, because feedback from previous webinars has been people find it a bit distracting if the chat box keeps popping up on their screens. So send it to me. Also to tell you, if you check your inboxes, you will have received some reading material on the subject of growing pains today. Apologies, we were hoping to get that out before, but Christmas, New Year, we didn't quite get round to it. It's a really good review paper. So, it might consolidate your knowledge maybe afterwards if you haven't had time to read it. Okay, enough of the yakking. We need to get on with the presentation. So I'm going to hand the microphone over to Nina. Nina, you're going to kick us off with growing pains. So I'll stop sharing my screen and away you go.
Okay, thank you. And thank you everyone for joining. Let's wait for the presentation to come up. So, growing pains, how do we bring the team together? And I'm sure we've all got experience with growing pains within each of our professions. And the title of growing pains is quite an interesting one, because we know that it doesn't actually relate to actual growth at all. And along the way, we've wanted to change what it's called to just be a little bit more accurate as to what it presents. Growing pains is a diagnosis of exclusion. And therefore, it's when we finally come to that conclusion, we might want to call them benign nocturnal limb pains of childhood, or we might want to call them recurrent limb pains of childhood. Either way, we have to go through an assessment process to actually decide that they're growing pains. And along the way, we don't actually know too much about what causes growing pains. It's actually quite poorly understood. So then when something's poorly understood, it's then quite hard to manage as well. But there are things that people have started to think, well, does this cause it? Does that cause it? And then along the way, we've decided, well, should we try this therapy? Shall we try that? And I think the bottom line is then that there's not actually a lot of evidence, to support what's going on. To give you some examples of those theories that have been tested, is like people have thought, well, is it hypermobility? Is it flat foot? Is it geniovalgum? Is it scoliosis? Is it a gait issue? And all these things that cause a person to walk differently, and then it causes pain. Well, not really found any evidence there. Then there's been queries around, well, it's linked to activity. Is it fatigue? And again, these kind of things haven't been fully tested, and we've not found out what's happening there. We've even thought around, is it to do with vascular perfusion? There's also been studies around children's mood, and sometimes they might feel a little bit more negative, or they might be a little bit more intense, or the behaviours might be different. So there's lots of different things that we try and find links to growing pains, but it's not actually sort of well understood in the end. Okay. I think before we start going through what growing pains is, I think it's then also really important to sit down with the people who have come into your clinic and start to understand their experiences, because these people have probably been going through a lot. Those children will undoubtedly be in pain. The parents will be worried. The child will be worried. It'll also have caused disrupted sleep. And I think as parents and carers, we're not, it's not an unusual situation, but it's something that it causes a lot of stress on the family. And not knowing what that pain is, it can cause a lot of distress within the family. So I think it's really important at that time that you sit down and you listen to their experience. So it's that general pain history, the onset, the duration. How does it feel for you? What kind of things are you experiencing? Some might say it's aching. Some might say it's cramping, it's sore. Some children might be really, the first time they've ever had pain, and it might be really worrying them. Listen to the child and what they have to say. The other thing as well is you've got to think about that overlap as well. You've got the experience of pain, but what else might be going on? Might that child have autism or mental health challenges? Might they be anxious? So it's trying to understand, well, what's important to them in that consultation, and trying to get to the bottom of it. You can't sort of straight jump into, this is growing pains and I'll explain it, off you go. You really do have to do that full examination and make sure that everything's okay, because it's a diagnosis of exclusion. So I think it is important that you explain, that there's not that clear evidence base or understanding around what growing pains are, but we are in a good position to find out, well, is there anything that would be causing concern? So along that consent process, you're wanting to make sure that, that when you're doing that examination, you give them that assurance that if you do find anything that you would like to talk through, that you would tell them. And I do find that really, really helps, reduce that anxiety. Okay. So I'm sure everybody, or I hope everybody, is aware of PGALs. It's something that's taught across England's medical schools. So pediatric gait, arms, legs and spine is one of those screening procedures, and it starts with 3 key questions to start with, around whether a child has any pain, stiffness in the muscles, back or joints, whether they have any difficulty dressing themselves, and whether they have any problems going upstairs. And some people think this is a rheumatology screen, but it's really good for orthopaedic, neurological, and the really lovely thing, as much as we talk about growing pains and it affecting lower limbs, equally, you can have systemic conditions that also affect the upper limb. So it's a really good screen for both upper and lower limb. But you would systematically go through this. It's not going to be specific. It's not going to tell you what's gone, what this presentation is, but it will start to tell you whether you have got any concerns. So you would systematically go through this battery of tests. Some of it is asking the questions first. Some of it is being keen on your observation. you're looking at symmetry, you're looking at muscle wasting, then you're looking at sort of skin conditions, whether anything's swollen. So really full observation, and then getting them to move along the way. And then that should tell you where you might need to focus further assessment. So what further assessment you do is up to you, what you do locally. Generally, the next port of call is something like Gallop, which is an assessment of the lower limb. It's specific to children, and it's evidence-based, all formed on consensus.
Nina, can I jump in for 2 secs?
Yeah.
With PGALs, just because I saw a question pop up, you can actually get PGALs as an app. So if you go to your app store, you can get PGALs and all of that information is on there. I'll be quiet now.
It's all right. And another really good place to go, thank you for the nudge there, is Paediatric Musculoskeletal Matters, so PMM, really, really good resource.
Yeah, PMM.
Yeah, so please do go on there, a fabulous resource section. Okay, so I think the next thing as well is that look around, sort of start thinking wider. What patterns of pain would start to cause concern? Now, you can theme these into much broader categories, but let's think along the lines of who might you want to refer to, because that pain isn't quite where it should be. So you've got things like orthopedics. You know, here you're looking for symmetry, you're looking for limping, you're looking for things that just you know, don't look right. You might have focal pain. It might be something that you want to refer to for imaging, or certainly that's how we work in the NHS. Along there, you might also get sort of bone tumours, etc. So you're starting to think, well, could this be an orthopaedic concern? You've got infection. Infection can come on quite quickly. And I think for both of these two, thinking how children are different, you've got people who like to grow. So with growth, you've got lots of cell division, you've got lots of vascular supply. So anything of an orthopedic concern, problems can happen quite quickly, including infection. So think about that. We've got neurological, so that could be neurogenic. You might be thinking about things like autism linked to toe walking, or it could be other things like cerebral palsy, but mild enough not to sort of fully see it. To the untrained eye, if you like. Then you've got rheumatology conditions. And in terms of pain patterns here, you might see more of what we call a diurnal pattern, where pain is worse, or it might be stiffness is worse in the morning and then the evening. And sometimes for children as well, pain patterns don't always happen, particularly more with the younger children. You might be also thinking sort of fibromyalgia as well. We get a lot of children with psychological challenges, and that can ultimately present in pain. And then we've got other things that let's put it in the complex category. So not to rule out sort of non-accidental injury, etc. So whenever you're thinking of pain, sometimes I talk to parents and sometimes the children around you to draw a graph. You know, and it was over a period of time, and the intensity of the pain, or when the pain happens, what does that graph start to look like? And certainly anything that's starting to get worse and over time, it's quite intense. Those are things that really are not linked to growing pains. Okay. So I use, where I work, we call them the Peterson criteria for growing pains. And as we said before, growing pains is that diagnosis of exclusion. There is no one test to say this person has growing pains. So first of all, we're looking at the nature of that pain. So like I said, it might be aching, it might be cramping, but that would be intermittent, you know, some good days, some bad days, and so it's usually pain-free days and nights, okay? Typically, pain might be more late evening and nighttime. But when that nature of the pain is starting to be really quite intense, and it seems to be worsening, that would start to cause concern. Then we're looking at whether it's unilateral or bilateral. Typically, growing pains are bilateral, okay? Unilateral seems to sort of point to more, there's a pathology in one specific area. And you're looking at location of pain. I think the key thing here is it should not be in joints. Do start to think of other things. Remember, joints are those areas of high sort of cell division, lots of vascular supply. So if you're thinking of rheumatology or an orthopedic neoplastic concern, you really need to be on it quickly, because it can do a lot of damage quite quickly. And then physical examination. So we've gone through PGALs. We would expect that to be normal, okay? And anything that falls out of that normal range, again, would be in that exclusion criteria. Now, okay, thank you. So we've got that kind of clear-cut sort of, you know, we'll say there's nothing quite clear-cut around growing pains, but if there are certain cases that you think, right, this is certainly feeling like growing pains, it depends on local protocols, really. It's whether you decide at that point that you really think, well, should I do an X-ray, a bone scan, any bloods to see if there's anything else underlying, okay? So, because let's say that there's probably up to 50% of children get growing pains, but do you want to place every child through that testing procedure? But it's a decision that you make at local level. Hang on, I'll press the right button. There we go. Is it coming? Yay. The other thing, and I was going to very quickly go through this, it's really important that you just determine whether a child is well or unwell, because it starts to separate out, you know, the good, the bad, and the ugly. And then also whether the pain is localized, whether the child can actually point to it, which is important, and whether that pain is quite diffuse. So just some key things here. Just remember that a child can be well or unwell if they've got juvenile idiopathic arthritis, just depends on which one. And you can, in a well child, you can have some really benign things like sprains and strains, but it also comes under the category of bone tumours, okay? And if you have got an unwell child, start to ask a little bit more. Ask about your fever, if they lost weight. Are they just generally feeling unwell? You might want to be looking for rashes, swollen stomach, etc. Right. And then just to sort of just give you that caution, well child, localized pain, do always think around, you know, whether it could be something more of concern like bone tumours, etc. Okay, so the final bit is the management and sort of bringing the team together. What do we do? So in terms of managing growing pains, a lot of it is that advice and assurance. But by the time someone comes to your clinic, it's very much a case of they probably want a little bit more than that. So it's around that shared decision making. Where do you want to go from here? Okay, so there is a low evidence base, but I think when someone's had the sleep disrupted, it's worth trying something. So things we try are things like stretching exercises. You may want to consider strengthening beforehand if things are tight. People find massage work. People find that pain relief, ibuprofen, paracetamol help. But it takes a while for it to work, so it's not always the greatest thing when your child starts crying in the middle of the night. Heat can work, but not for everyone. Sometimes people prefer a warm bath on an evening. They feel it sets the child up for a good night's sleep. And then there's also some theories that the insoles could help, and we certainly do try them with children. It's a bit hit and miss, but I think certainly it's worth a try. And there has been that question around vitamin D. I think it's just it's a good vitamin to have in your body, but whether we do it as a sort of mainstream treatment is up for debate, really. So there's lots of things you can try. But yeah, we've got lots of children with lots of growing pains, and I think fair to say the majority will be fine. But it's finding that needle in the haystack, that really important one, two, etc. And this is when we start to bring the team together. I've totally forgotten the poll. I'm really sorry. We're going to do that in a minute. So before I finish, shall we bring a poll up? Yeah, we've got a question. See if you were listening. Yeah, okay. So, right, which statement's incorrect? Do you want to read them on the screen and vote? Yeah. Yeah,
that's what we normally do, Nina. So yeah, folks, if you just give us your answers as quick as you can, we'll just give you a couple of minutes to do that, and then we'll go through them.
Excellent, thank you. Really sorry for forgetting. I remembered, and then someone said 5 minutes. It put me off.
No worries. No, it's good to do it now.
We're coming to a. Ooh, still going.
Yeah.
Okay. We've all answered now. Yeah, right. Okay, so growing pains, yes, they do disturb sleep, but equally that can be a cause for concern for other conditions as well, but growing pains still fits in that category. We sometimes get a little bit, well, we are more concerned when that child is unwell, they've got fever, they might be having night sweats, so sometimes that's the deciding feature as to whether it's a concern or not. So whether there are abnormal clinical signs, there isn't as a general rule. So you would be looking at p-gals and everything's in normal range. I suppose here the debate comes, if you've got a mild bit of genu-valgum, majority of children will have some sort of lower foot posture. So I suppose it's where that cut-off is as to whether it's an abnormal sign or is it just an anatomical or, a variance in the population. Symptoms are typically bilateral. I know in the pre-reading it said unilateral, but it's bilateral. Usually unilateral tells you that there's something specific in a particular area. And it's limping. This is the correct answer, which is limping is not common, and that is an orthopedic concern. It's an orthopedic red flag or general red flag. Okay. And then, yeah, the symptoms do tend to be intermittent as well. Anything permanent is a concern. Okay, so thank you everyone for joining in on that. Okay, right. So it's bringing the team together. Yeah. Let's go to the next stage.
Yeah. So Nina, thanks so much for that summary. That's fantastic. So that hopefully that gives folks the sort of overview of the condition of growing pains. What we thought, just in the interest of where we are with time, the team, as you can see, is all together, and this includes orthopedic surgeons. So Michalis, I'm going to now invite you to share a case of yours. I think this is a case that you have posted on the PodiNote website. So hopefully, if you've been on that website already, you'll know this case, but you're going to take us through us again, I think, and walk us through growing pains in this particular case, whether it is, where it isn't, what's your clinical thinking on this one?
Thanks very much for that, Gavin. So I've just checked on PodiNote. I think we had 36 views. So probably because it was a bit of a last minute thing, but I did put the PodiNote link on the chat. So please feel free to go. It's for free. You subscribe, and then we can use it for future educational events. Anyway, let's go for the first case. These are real cases of mine. This was an 18-year-old young lady who just started her military training. So she presented to us with a 1-month history of generalized diffuse pains to both lower limbs. And we're talking about both thighs, both shins, but also both feet. And that was it was only 6 months after she started basic military training. She also reported, when she came, she reported 2 episodes of inversion injuries to both feet while jogging. She was an otherwise fit and healthy individual. She did not receive any medication. On clinical examination, she, as I say, she did have pain on palpation throughout, from the hips down to the feet on both sides. She was able to weight bear, and there was no limping, and she had a normal gait. Now, looking at the joints, there was full range of motion on hips, knees, ankles, and everything was normal. When she came, we did some blood tests, and they were normal. So if you go through, Nina's presentation was excellent, showing you how you can exclude basic things such as infections and so on. So you can see here that all the infection markers, they're all normal. Normal CRP, full blood count was normal. Normal ESR, there was no problems with the bone profile or liver function tests. And for some reason, the GP had already arranged for a DEXA scan, which was normal. So her bone density was normal. So unless Nina, James, or Gavin, you have any questions? You got any questions before we put the poll up there? Anything that you want to know from the clinical examination, from the history, that's going to help also our podiatric colleagues to answer the poll? Nina, you're about to talk, tell me.
I was wondering, was
Yes.
there any sort of neurological examinations or
Yes,
muscle?
it was normal.
Beat me to
No,
it,
sorry,
Nina.
I missed that. Hey,
No,
That was my question as well.
Yeah.
okay.
So neurological examination was absolutely normal.
Right. Okay, that's good. Thank you.
Anything else you'd like to know?
Yeah, there's a question on the chat about
Yes.
was she still growing? So she's 18. So not
No, I know
from
it's a
her
pediatric
limbs,
one, but
I guess.
actually it could happen. This case, which I'm going to show you, could happen to anyone. So she's a young lady, so she was not. No,
Yeah.
she probably, finish growing by, usually girls by 15, 16, 2.5 years roughly after they start their period.
Another question on the chat: Baton score. In other words, ligamentous laxity. Any sign of that in this?
It's a very good
this
question.
child?
I'm sorry we didn't put it there, but she was kind of a borderline, so 6 out of 9 on the Baton score. So a bit of hypermobility there.
Okay. Folks want to know about anything wrong with her spine, any skin rashes or a family history?
No skin rashes, no family history as far as I'm aware, and there was no scoliosis or anything similar. No lower back pain. Actually, no lower back pain. All her symptoms down to both legs.
Okay. Another question: any history of amenorrhea?
Very good question. No, because you can have these female triathlon,
Female athlete triad.
That's it. Yes, correct. So no amenorrhea.
Okay.
Okay, let's go to the poll then. Right.
Yeah.
So what I would do, I've got that. Good. So go for it, guys. You've got a couple of minutes there to give us your answers. By the way, this is completely anonymous. We don't know what you go for, and just don't be intimidated just to put your opinion there so we can discuss. You can put your answers, Nina and James. I do know. I haven't told you what this is, so.
No.
I don't think Gavin knows. If you don't see the first answer, just try to extend it with the arrow, guys. Okay? So expand it, kind of wide-wise.
Or you can just hover over the question.
Oh, thanks, Ruth.
The answer even, sorry. If you'd like to talk through the answer, please.
Thanks very much, Ruth. So let's go through the answer. So the first answer is initiate local treatment, whatever that's going to be, to both legs, and follow up in 2 weeks. And the majority of you went for this answer, about half of you, so 48%. And that's a very reasonable answer, isn't it? If we are not sure and we have a complex thing, that's what we should be doing. Always bring it back, follow up, and do whatever treatment we want to do, or say, have some time off and so on. Then if we go through the second one, recommend 2 weeks off and discharge. So discharge, just be very careful when you have somebody there who has kind of an atypical, this is kind of an atypical thing, they have a lot of pain on palpation or not, even if you think it's growing pains, because growing pains is the topic. I would say, and correct me guys in the panel if you think different, just follow up in 2 weeks, even if it's a telephone follow-up. You want to make sure that it kind of settles down, they're doing a bit better. Usually growing pains are intermittent, okay? They should get better and then come back again, that kind of thing. So I wouldn't go, I'm glad that only 3% went for that answer. Arrange for x-rays of both legs. Now, Nina, help me here, and James. How easy it is for a podiatrist to do x-rays? So do they have to liaise with somebody else to request?
Depends on your setup.
Okay.
So for where I am, I can refer for it straight away. Some will have to be in a specific clinic, depending if they're working under the remit of a GP with a special interest. So then they can do MRI, CTs, the whole lot. But some podiatrists may not have any access to radiology. They'd have to go via their GP.
Yeah,
So we're not, yeah. So thanks so much for that, James. We're not here to say that we should X-ray everything. Okay, that we're completely, against this kind of approach, even as an orthopedic surgeon or as a podiatrist. But and that's one of the things that these kind of joint education events show, is that we just need to liaise with each other. Okay, orthopods with podiatrists, podiatrists with orthopods, radiologists, GPs, whatever. It's always good to have this network. So yeah, so arrange for an X-ray is a very very reasonable thing to do if you think that it doesn't get any better. If you don't think you should be doing it at this stage, you can at least do it in 2 weeks' time or whenever you decide to follow up that patient if it doesn't get any better. So it's a reasonable thing. I haven't put there what kind of an X-ray of the legs, because it goes from the hips down to the feet, and of course you want to reduce the amount of X-rays you do. But I think I'll tell you what we did later on. Now I put the bone scan. Some people decide to go for a bone scan, about 4%. Bone scan it involves quite a lot of radiation, and usually, and then even the same thing with any other scan, MRI, CT. Although MRI does not have radiation, we always, if you want to do any imaging, I would first, start with simple things. Do some X-rays. The easiest thing would be for somebody who has bilateral, so both lower limbs, just go for some long leg views. That would be the easiest thing. If you think one, the femur or the tibia or the hips or the knees, then you go for AP lateral views. That's kind of the standard thing. Refer to an orthopod, you could do that, or you can follow up. And if you're not sure, I think one of the things that it applies to us as orthopedic surgeons is we all need to know our limitations. So if we think we reach the limitations, maybe we can just discuss with others, even with peers. We discussed with James and Nina on the podcast how important it is to discuss with peers first, or have a friend there that you can call, or you can discuss that too, and then feel free to refer. We do it as well to the same same specialty. Interdisciplinary referral, whatever. This can be an orthopod, this can be a rheumatologist. So I think all of them, the reasonable answers, apart from the discharging thing and then the bone scan at this point. Let's go ahead with the presentation. So, okay, bilateral unspecific lower limb pains. So somebody could say it could be growing pains, and as you probably imagine, this is not a growing pain. Okay, we actually published this. We published this back in 2011. And I've got here I've got a QR code, so you can all scan this and you can read about this, or we can send it to you as a post-webinar reading material if you like. Basically, what this young lady had, she had multiple stress fractures on all bones, on both femurs, on both tibia, and on metatarsals in on the X-rays. So we X-rayed, you can see here she had like femurs and feet, because she was in a lot of pain. So that was not a kind of a, it was quite intense, this kind of pains. And we put it down. There was no other problems with her. She was fit and healthy, but she was suddenly exposed to a lot of repetitive cycling loading to her bones, which kind of overwhelmed the kind of reparative capacity of the skeletal system. And she had all those stress fractures. You could see it on the X-rays. The thing with the stress fractures is that you don't see it on the initial X-rays if you first present. That was already a month after, so we could see the callus formation. So it was already building up. And then we also did the bone scan because we were worried about other things. And then we did not have to do anything. So 3 months later, she kind of, my symptoms kind of settled down with just rest. But that's just a thing just to show you this kind of presentation resembled growing pains. And when we say growing pains, and Nina said it, growing pains have nothing to do with growth. There's no evidence. We still say growing pains, but it's kind of recurrent limb pains that can happen to a growing individual. In this case, a young adult one. So always, have a very high suspicion. So that's me done with this case. Gavin, are there any questions from the chat? Or Nina or James, any questions?
There's a few comments really about whether there was anything unusual in her diet. a vegan diet. And my question to you would be, I mean, this is kind of unusual to have multiple stress fractures. Do you think there was some maybe metabolic problem going on here? I know all your blood tests were normal, but they don't pick up everything, right?
We did all the hormonal investigate blood tests. There was nothing there found, nothing whatsoever. And she wasn't. I mean, I can't remember if we specifically asked about vegan diet, but I don't think it was. It was nothing there out of the usual, I think.
Sure. Yeah. James, Nina, any comments on this case?
I think the only other thing, because I didn't mention it in my presentation, because sometimes people say you get growing pains within the feet, but I would just argue that that's not possible because there's too many joints there. So but no, it's really interesting case. Thank you. Yeah. I suppose it's that systematic inquiry, isn't it? If it's not neuro, if it's not come from the spine, then it's only localized below the spine. So what's the only thing that could cause it to be bilateral? Well, it then would be linked to activity. Yeah, it's sort of that process of elimination, isn't it? So yeah, no, really interesting. Thank you.
And I think in her case, the pain was persistent. It was there all the time and it was intense. And that's kind of where your suspicion just goes very high. Well, that doesn't sound like growing pains, which can be intermittent. Even during the day, there can be more during the evening or at night, and they should get any better while she just had it all the time. And it was really, she couldn't do any sports or anything like this. That there's a high suspicion there.
So it comes back to your further investigation there, doesn't it, Carlos?
Correct. That's one of the red flags, as Nina showed us on her nice slides. Do you want to go ahead with your case, Gavin?
Yeah, sure. While I'm doing that, there's a couple of questions there in the chat, Michalis, if you can maybe answer those. So there's questions about different growing pains and growth spurts, and a question about her foot shape and so on. So yeah, if you can handle those for me, I'll share another case.
That's very kind. Thank you.
All right. So continuing the theme. So consider this case. This is a younger child. This is a 3-year-old boy. He's had problems for about 8 weeks, complaining of pain, and it seems to be in his left leg. But bear in mind, he's 3, so they're not always so specific about where. But it's been a consistent complaint, and his parents can't ignore it anymore. Nothing else, just pain. He's well, no fever, no history of an injury. His parents have noticed that he's got knock knees, and they wonder whether that might be related to the fact that he's got pain. Otherwise, fit and healthy boy and fully immunized. So when he comes to see you, the pain, this complaint is of pain. It seems to be localizing around the knee and the proximal shin on the left side. His parents report that he does complain of pain in the day, but it does seem to be worse at night. But that he gets around. He's not limping. He doesn't seem to be stopping playing. He generally seems a pretty happy, healthy boy. When you see him in the clinic, he looks very comfortable. He runs around the place. He walks normally. He's not limping. When you examine his hips and his knees, you find nothing abnormal in the range of movement, no stiffness and no irritability. You notice that he does have genu valgum, which is symmetrical, and he also has flexible flat feet, both sides. Also, the left leg, on the lateral aspect of it, it feels a bit swollen, but it's not red, it's not hot, it's not tender. There's no mass to feel as such. It just looks slightly bigger in terms of its girth. So let's suppose, we're going the wrong way. Here we go. The treating clinician, who's a pediatrician, had clocked the fact that growing pains typically is bilateral. So there are some features here, but this is a bit of a red flag. It's unilateral. So the pediatrician arranged these x-rays, which have been reported as normal. So fair enough, that's reassuring. Oh, I'm going the wrong way again, sorry. So in conclusion, the pediatrician thinks, well, there's genu valgum and there's pes planus. So perhaps the combination of those two is the problem, might be causing the symptoms. Alternatively, this could be growing pains, but either way, what they'd like your help with is a trial of orthotic management in this case. So what do you think? I've got some questions for you now. So Ruth, can we share the poll, please? So give us your thoughts on these options, and then we'll go through it. Okay, we're above 80%. Shall we stop there? Let's see what you all thought. All right. So most popular answer is suggest different imaging modality. So most of you don't feel confident that we have got to the bottom of this, I think. There's some votes for physical therapy and orthotic management. So presumably you feel that there is pathology here that could be treated by one of those two modalities. Not many takers for repeating the x-rays. I guess you believe them the first time around. Referral to OrthoPod, a few of you feel that would be an idea. None of you very keen on oral medications, interestingly. All right, well, let's take the story on. So here's my interpretation of this case. There's some worries here. The first is that the symptoms are unilateral. And as you're getting the message, growing pains is very typically bilateral. Not always, but most of the time. So that's got to be a worry. Second red flag, pain in the day. So children typically are fine in the day, certainly at the early part of the day. This child was complaining of pain in the day as well. And finally, there was this vague swelling in the leg. It might be vague, it might be subtle, but it's an abnormal clinical sign, and we can't really rest on that. So it's a very reasonable thing to do the x-ray, but that x-ray was indeed normal. So I would argue more investigation is required. So to be honest, I can't remember if we did this investigation or if it was already done when it came to our hospital. But the decision was to go for an MRI scan. Very reasonable thing to do because there seems to be a soft tissue problem here, which we haven't got to the bottom of. Ultrasound would probably also be reasonable. So here's the MRI, and it shows some pretty dramatic abnormalities that you just would not suspect from a child who is so well. So here you can see an abnormality in the bone just below the joint. There's something going on in the proximal tibia there. And on this so-called axial view, you can see there's a large fluid collection in the soft tissues, which would explain the swelling that you'd seen. So those of you who thought another investigation would be helpful, definitely. This then led us to think that the most likely cause for an abnormality in the bone and the symptoms and the swelling and all of that fluid was probably infection. And my working diagnosis here was infection, osteomyelitis. But how do you explain the fact that this kid was so well? Well, there is a subtype of infection called subacute, which is much more insidious in onset. And that would explain why the infection was in a slightly unusual place just below the joint. And it would explain why the kid seemed so well. So we took him to theatre and we drained off that fluid and we took a sample from the bone itself. And this is what we got. This child has TB. And this is what is called, in an old Victorian term, this would be called a cold abscess. So it is an abscess, but it's not hot, it's cold. Very typical of TB. And those of you who work in developing countries, I'm sure there must be some on the webinar, you'll probably have got this before the rest of us did. So what are the learning points? There are 5 learning points here from this case in my book. First of all, I'd be very careful about attributing normal variants, which includes genu valgum and includes pes planus in a 3-year-old, flexible pes planus, as a cause for the symptoms. because by definition, these are normal variants and they bother parents, but they do not bother children. They don't cause symptoms. But what if you're not sure? Is this really normal? Well, here's a tip for you. Here's the 5 S's. If you think of the 5 S's. So if a child comes with any sort of presentation, you want to know, do they have any symptoms? Is there lack of symmetry? So it's affecting one side rather than the other. Well, that was certainly the case in the case presentation I've just showed you. Is there any stiffness, lack of movement? And is there any systemic disease? So fever, losing weight, sweating at night, those kind of things. Any of these should signal to you that this is not normal. And the final one that you just have to think of is a weird condition called skeletal dysplasia. So any child, for example, who's coming with genu valgum but has a history of skeletal dysplasia, this may not be a normal thing for that child. So this probably implies that it's not a normal variant. So this child had symptoms and lack of symmetry. So we're dealing with something that is not normal. But what? Well, it's very important. I think, you know, this is what surgeons can bring to the party, I suppose. We're very keen on diagnosis before treatment. It makes me anxious to start treating patients before a diagnosis. So this is why I think it was very important in this case to reach that diagnosis, because all of those other things that might have been tried is simply going to delay a diagnosis. And with infection, that can have some long-term effects. Fourth take-home message, musculoskeletal infection, or the books will tell you sick, fever, not moving, irritable, won't walk. That is not true. And it's not just not true for TB, which is notoriously insidious, but even pyogenic infections can be surprisingly subtle nowadays. The pathogenesis seems to be changing. So don't be afraid of flagging that up as a possible diagnosis, even in a child who seems well. And there's an expression in the medical world. I don't know if you have this expression in the podiatry world as well.
Yes.
I don't think it's very, you have it. I don't think it's very helpful. Common things occur commonly. Well, yeah, sure. Rare things do occur, and particularly in pediatric practice, which is one of the things that makes it a lot of fun, of course. All right. So that's me done with my case presentation. I'm going to stop there. Michalis, we have, by my watch, probably about another 13 minutes left. I think you have another good case, unless there's anything to discuss on that particular case.
No, I mean, we should tell people, I mean, the cases that we put there, there might be, they're not growing pains, they resemble growing pains. And then we just want to say, and it shouldn't come as, you know, you come out of this webinar thinking like, you know, you should all be intimidated and asking for, I did say that before, you know, we need to get x-rays. All what we're saying is always have a high suspicion about something that doesn't sound and look right, okay? Something that it's getting too long, something that it's too intense, something that doesn't sound right, you know, just, you know, speak to somebody else, okay? Speak to your friend, speak to your peer, speak to somebody, you know, read about this, and do not be afraid to refer. We do this, as I say, you know, you should be doing that. And that's the kind of things that we want to bring by this cooperation. Any comments, James or Nina?
No, totally agree. No, well said.
Yeah, I've got none on that.
Right. Let me show you the other case that I have. 1 second. Right. Can I say, I would like to congratulate Stuart Morrison. He's the only one who really had the guts to write something on Podinote on a very short notice, because we only put it up today. And I don't know him personally, but well done. I saw he commented on the chat as well. So feel free to comment, and hopefully we will have more opportunities to for you to comment, you know, reply to each other on this forum. So the second case is a 15-year-old adolescent who is obese, markedly obese. He has a diagnosis of diabetes mellitus type 1, so he's on insulin and oral medication. He also receives supplements for vitamin D deficiency. Now, he goes to a special school and he has an educational healthcare plan. So it's a kind of an autism, ADHD, but not a specific diagnosis. Mainly the reason for this is because I only met them just before Christmas, on the 21st of December, 2022. So this is a very recent case. And then I saw with Mum, and she wouldn't give me a lot of past medical history, but going through the referral letter that I had, this is a child with a need plan, comes from a family which has been declared as vulnerable, has a dedicated social worker, and they have been referred to social services and safeguarding team in the past. So his symptoms, and that was the referral, was that he had right leg pain for the last few years, okay, 4 to 5 years, mainly on the right, but then he says intermittently he could have pain on the left. And when he say the leg, he means from the hip down to the feet, okay? The symptoms were diffuse, thighs, shins, feet, not specifically on joints, okay? Let me give you a few more about the past medical history. So when I asked him about the symptoms, he wouldn't give me a lot of, because of the background, as I explained to you, he wouldn't give me a lot of information. Mom would not give me a lot of information, okay? I asked if it's more during the night or during the day, they wouldn't tell me. They would tell me for sure that he wouldn't be able to do a lot of sport activities. But then again, you would think for a child like this, it might be normal not to do sport activities, just because he wouldn't be interested. It was very difficult to figure that out. On clinical examination, he had a normal gait. Oh, I wouldn't say anything about the gait because I've got a video to show you. But anyway, I've got it there. And then you will see about the feet. And he had pain on palpation mainly over the right leg. There was a bit of pain over the left thigh, kind of left upper shin. So I'm going to show you here the video. So you can see how he walks. Really, that gait is not abnormal. It's a normal gait. I don't see any obvious limping there. He doesn't seem to have. You can see that there's no. There's a bit of there's a bit of symmetrical external foot progression, only a bit of outtoeing on both sides, but nothing asymmetrical, especially if somebody has kind of a right leg pain, isn't it? Feel free to interrupt me, Nina, James, or Gavin, if you have any questions. Now, here he is. That's his flat feet. And the reason I'm showing the flat feet is not because we're doing a webinar for podiatrists, is because Mum told me that he was treated when they went to the GP a couple of years ago. He gave him insoles because he was very worried about his feet, especially the right foot. GP told them. GP told them that the flat feet deformities that he has might well cause lower limb pain. And there he is, pictures from the front, from the side. And you can see here the collapse, the medial arch on both sides. You could also see the kind of valgus position of both heel bones. Right, should we go for the poll, guys? Any questions before we go to the poll? Sorry. Nina, James?
No, all good, thank you.
Okay, let's go for it. Let's see what you think. Are there any burning questions, Gavin, from the chat for me? Okay.
Not at the moment. No, I'm just answering some questions. So I'll let you know.
Good, thanks.
Do you want to talk through the answers?
Thanks so much, Ruth. If for those who went for the second answer, would you please tell me if, you know, what would you expect to see if you have any X-rays? You want to put the chart so I can discuss while I'm going through the answers, if you have any ideas. Otherwise, don't worry about this. So, first answer, prescribe insoles and follow up in 6 weeks. Again, that's it's a safe thing to do. You know, you've got somebody with flat feet. If you think that there's problems there with a foot, you know, you can do that, but make sure you bring them back, okay? The only difference is, what if there's something else that you might worry? You might want to bring them back in 2 weeks rather than 6 weeks. But then again, you might think, will the insoles have a lot of a difference? Nina?
No. The things that concerns me is if you've got thigh pain, I've yet to see success with an insole. So that's my 10 pence.
Michalis, you've also got the history where he's been to the GP before, where you said he'd previously been prescribed orthoses.
That's what they said. That's what they said.
But we don't know what orthoses they were and what the clinical rationale was at that point. No, we don't.
And I think the other thing, sorry.
They wouldn't give me that information either. So anyway, 32% went for that answer. You know, I'm not so sure. And even at 6 weeks, you know, will you see a difference on the insoles? Will you see a difference with the insoles in general with this patient? You will see in a minute that you probably won't, but you know, it depends on the what was wrong there. So arrange for X-rays of both legs, and I specifically put their long leg views because it's on both sides. You might be surprised, you're not going to see this pathology with long leg views. So that's the only thing, which I will tell you what it was. Refer to chronic pain clinic. You can't do that. In our institution at the Evelina London Children's Hospital, where I work as a consultant, we have the pediatric rheumatology team. They're mainly physiotherapists together with rheumatology consultants who do those chronic pain clinics. And it's a kind of an exclusion diagnosis. You know, if you don't find anything else you do some investigation, you don't find anything else, then you can refer to them. And growing pains, I always say it's an exclusion diagnosis. You know, if you don't find anything else, then, you know, you can say that these are kind of growing pains. It could be one of your options, but it's only 1% of the 273 answers, so not a very popular one. Refer to an orthopod, not a popular one. Refer to a rheumatologist, even and less common. So I have to say, when he came, I did know the diagnosis because he already had an X-ray. So after a few years, somebody decided to do an X-ray of the hip joints. And when we do an X-ray of the hip joints, we do AP and frog laterals. And then it doesn't show on the AP, it shows only on the frog lateral views. And the question is, I don't know exactly what the hip examination showed at the time. When I examined him, the hip examination was not too bad, okay? When you have symptoms only on one side and you have a hip pathology, you probably see some kind of reduced range of motion. Remember Nina's slide there. If you have a reduced range of motion, you know, you can get that. But also remember, whatever the presentation, you need, if somebody comes with a whole lower limb symptoms, you need to check the joints. You need to grab the leg and check the range of motion, otherwise you won't know. Because obviously in his case, he had this pain for many, many years. They missed it because I presume nobody went there to examine his hip joint, because if they have done this, they would have seen that he has some reduced range of motion. Okay, so what this patient has, and I can tell you more about this. Just 1 second. So if you can see the red arrow, that's a frog lateral view. That means both legs are opened like that. So it's called what we call a slip capital femoral epiphysis. Okay, so the femoral head just slips over this very weak area of the growth plate, and it's very common for marked obese patients with low vitamin D, especially at his age. And then he will need now a major hip surgery because this is a quite marked condition. The only thing is, and I haven't shown you, this is the X-ray from the 23rd of November, so a month before I saw him. I didn't put there the X-ray from December when I saw him. He managed to do, because he has a high pain threshold, he managed to do an osteochondroplasty himself, like the procedure that I would do to shave that bump away. He did it by himself by doing a very very consistent bike, which is quite an interesting. Anyway, I don't want to go much into the hip pathology because that's not our point. But what I was trying to say, when you have a child, you might have autism, might have learning disability, that does not mean that they don't have a serious issue. So you always need to take things seriously, and you always need to do a complete examination. You know, when the whole limb is affected, which is the case with all growing pains, try to examine each joint, start from the lower back. Sometimes you can have even growing pains from the arms. Just do a full examination like Nina showed you in her slide. Any comments, guys?
Yeah, and for the Sufi that I've seen, when you look at the gait, what you tend to see is that the thigh crosses the other thigh, and you can slightly see it in your gait video as well. And obviously you've got your Trendelenburg as well, but yeah, that's always the telltale sign, and usually you've got that abduction of the feet as well. But yeah, it's always been consistent. If you sort of look at them standing face on, one thigh will just be a little bit in front of the other, because obviously things are stiff.
It's very subtle though, and it's very subtle because normally with a scoofy, the slipped carpal femoral epiphysis, you could get an asymmetrical external out-joint gait, and the Trendelenburg's gait would be very, very marked. While in his case, because he kind of self-healed himself, he was doing this bike like very, very fast with a high pain threshold because of his kind of neurological background. He managed to take off the bum himself with the edge of the acetabular socket, which is extraordinary. But anyway,
it's impressive stuff by the child.
It is. But you know, this is a very atypical appearance. I just wanted to make the point there. Right, Gavin.
Yeah. So thanks. Great cases that you presented, Michalis, and I think what they all share in common is that your two cases and the one I presented actually, that one, diagnosis is important, and two, these are diagnoses that are often missed and misdiagnosed as growing pains or something else for understandable reasons. That, I mean, as Nina was explaining, yeah, what you've described in the gait is absolutely right. But you're an experienced clinician and you know how to see this. It can be surprisingly difficult, actually. You know, slipped capital femoral epiphysis, notorious condition for misdiagnosis. So we're just over the hour. Hopefully folks will indulge us for just a few more minutes. What we would like to do, we have one more poll for you, which is about future topics. If you've enjoyed this webinar, then great. We've enjoyed it. We'd like to do some more. So we're just going to show you a poll now while we chat. If you guys could fill that in and let us know what you think about these as potential topics. So just give us a yes, no, and a maybe for whether you are interested in these topics. And hopefully we'll get some more webinars underway in the future. But just to sort of sum up while folks are finishing that, I mean, what I've taken away from this, we've sort of made our point about diagnosis before treatment, and that's what surgeons can bring to the table, because we have access to those kind of investigations, which, as has been pointed out, podiatry services sometimes do, but particularly in the private sector, they can struggle with that. But what we struggle with as surgeons, once we've reached our diagnosis of exclusion and we've got growing pains, we don't have much to offer really, and we rely on an extended team to help us manage these patients, because you know, as you guys have pointed out, pain, distress, lack of sleep, and all we've got is as surgeons to say, well, you know, guess what? There's nothing wrong. And, you know, most parents are going to think, are you kidding me? Like, is that it? So not surprisingly, we don't get on so well with these kind of cases. So we often rely on an extended team. What I'm interested to find out is how podiatry services fit into that, because I mean, we're familiar with working with physiotherapists. We've been doing that for many years, and that's often a route that we take. But, you know, what are your feelings about it, James and Nina, in terms of how we bring this team together?
I think it's when you look at the prevalence of, let's say, growing pains, you've got to start thinking, well, where's the workforce? How do you make best use of your workforce? And if you certainly want that screening, do you start with allied health professionals first, but then also pathways that are joined up, so that there is that clear understanding of when you would escalate care and the speed of access to care when that's needed, the right access to imaging, etc. It might be bloods. Or is it that they all go to orthopaedics and then they trickle back down again, or is it a bit of a sharing process? But yeah, I think because of the scale of growing pains and because basically lower limb concerns are really, really common, is it better that you do start with allied health professionals first and then escalate up, so that essentially you get the really tricky cases? I don't know. James, what's your thought?
You were saying as well there, Gavin, about from a private practice perspective as well, that can be slightly more complex, because obviously when you're hospital based or health centre based, that's far easier to build up those links. But it's making sure, if you're in the private practice sector, that you do speak to your local GP, speak to your local orthopod, so you actually build up those links, write to them, make sure that they know who you are. And offer to go and spend some time with the orthopedic guys, so you know actually where do I fit in this process, and build those links up, because obviously you can feel slightly isolated in private practice if you're a one-man band and that's all you have. So, but without you putting yourself out there, they're not going to know you're there anyway.
Yeah, you made that point on the podcast, didn't you? And you're absolutely right. You have to be proactive about it.
Yeah,
particularly where orthopedic surgeons are concerned. I'm not sure pediatricians maybe know you guys better, but we're not really familiar in the pediatric world, at any rate, with how we can work together. But we need the help, basically. It's a cry for help, but it does need that sort of personal connection. And I think the reason I mentioned private practice, somebody mentioned it in the chat, and it sort of occurred to me, actually, it's a specific problem there, isn't it? Team working is far more common in the NHS sector, but
it is.
You have to go that extra mile.
Yeah, it makes it does add that extra challenge with podiatrists working, because there's several podiatrists who solely work in private practice, and that is it. So they've got to almost go that extra mile to make sure that they've got that team around them and the links that they've worked so hard to get. Where you're working in the hospital or you're working in health centres, you have access to those, even if where we alluded to earlier, some clinicians will be able to send for x-rays, send for scans, but some won't. But you are there, able to access the GPs immediately and through orthopaedics. Private practice, you've just got to put a bit more work in.
Yeah.
And if I may add, James, orthopedic surgeons, majority of orthopedic surgeons appreciate when the podiatrist will come and approach them and ask for advice, or just work with them within the same kind of team. So we do appreciate this, and it works mutually.
Yeah.
Well, guys, the time is marching on. We said we were going to try and keep to time. We failed, but we're not too bad. So, but I'm going to, as moderator, it's my prerogative, I'm going to call a halt to it now. I would like to thank you all on the panel. James, Nina, McAllis, thank you so much. Thanks to Orthopaedic Research UK, wonderful people that you are, for organising it all. Thanks to everyone for joining us. You will be getting a request for feedback. We love feedback, even the hate we can learn from. So please send us your feedback. And, if you've enjoyed it, let us know. We'd love to do more. If you think that's a good idea, let us know. Thanks very much for joining us. Good night.